Dear students, welcome to the discussion on the most happening and the most important topic for the upcoming INI-CET as well as the NEET PG exam. So what topic is that? Yes, it's nothing but COVID-19 infection in pregnancy. Okay, COVID has changed our lives upside down, right? So this is where, from the exam point of view, this is where you all expect maximum MCQs from. Yes? So shall we start our discussion? Yeah. Now we're exclusively going to discuss about COVID-19 infection in pregnancy. Okay. So what are the do's, what are the don'ts, what is the ideal time for delivery and what is the ideal mode of delivery, when to admit the patient, when to advise her on home isolation, and what about the vertical transmission, what about the postnatal care, whether breastfeeding can be allowed or not. All these questions are going to be answered in the next 1 hour of our discussion. So kindly concentrate on the MCQ points so that you make at least 1 or 2 MCQs in the upcoming INI-CET exam. Okay. So the first question here is on vertical transmission. So we all know what the mode of transmission is for COVID-19, right? Yes, it's man-to-man droplet infection. But yes, when it comes to obstetrics, we first worried about what? Vertical transmission. Yes. So students, tell me, is vertical transmission seen with COVID-19 infection? Does it spread from the mother to the baby through the placenta? Yes or no? What's your answer? Yes, definitely yes. Okay, vertical transmission is possible. Vertical transmission is possible. Vertical transmission is seen. It does spread through the placenta. It does spread through the placenta to the fetus, but the incidence of the rate of infection, fetal infection, is very, very less. Okay. So, fetal infection is very less, but yes, transmission is possible. Okay. Fine. Very rare. Okay. So, tell me some viruses which spread from the mother to the baby by vertical transmission. Yes, we do have viruses, we do have bacteria, we do have some microorganisms which spread from the mother to the baby through the placenta, right? So tell me some viruses, name some viruses which spread from the mother to the baby through vertical transmission. Yes, what comes first to your mind is HIV, right? HIV. When I say vertical transmission, what comes first to your mind is HIV, yes. But yes, there are other organisms which are more contagious than HIV, like say hepatitis. Hepatitis B is more contagious than HIV. The rate of transmission, the rate of vertical transmission is very high with hepatitis than HIV. We have chickenpox, we have rubella. All these can, spread from the mother to the baby through the placenta, what we call as vertical transmission. So, coronavirus also spreads from the mother to the baby through the placenta, but the incidence as of now is very rare. Okay. So, what about the rate of infection in a pregnant lady? So, is a pregnant lady more susceptible for the infection than a non-pregnant lady of the same age group, or she's less susceptible, or the rate of infection is the same? What is the correct answer? Remember, rate of infection is not, different for a pregnant and a non-pregnant lady of the same age group. Please take it from me. Infection, rate of infection is not high for a pregnant lady, but what is high is only the severity of the illness. Okay. So, rate of infection is the same as for a non-pregnant lady. Same as for a non-pregnant lady. Okay. The rate of infection is the same as for a non-pregnant lady. Okay. So, rate of infection is not increased during pregnancy. And most of the infections seen during pregnancy are asymptomatic. Okay. Like how a non-pregnant lady is, most often asymptomatic. A pregnant lady also does not always present with symptoms. Most of the infected pregnant women are asymptomatic. Okay. So, are all infected women symptomatic? Are all infected women symptomatic? No. I told you. Yes, most of the women are asymptomatic. So, what is the MCQ importance in it? So, guess what percentage would be symptomatic? Yes, what percentage would be asymptomatic? What percentage would be symptomatic, students? Make a guess here. Okay, take it from me. 74% of pregnant women who are infected with COVID-19 are asymptomatic. Okay, 74% of infected pregnant women, 74% of infected pregnant women are asymptomatic. Okay, they are asymptomatic. So what percentage of them would be symptomatic? Yes, around 25 to 26% of the remaining infected women would be symptomatic. Okay, so only 26% of them are symptomatic. Other infected women are asymptomatic. So most of the infected women are asymptomatic even during pregnancy. So you understand that even during pregnancy, the number of symptomatic women are not high, but only the severity of the illness when the woman becomes symptomatic is, high. Okay, so severity is what is important. Once the woman becomes symptomatic, then she rapidly progresses to severe disease. Okay, if she becomes symptomatic, then the severity of the illness is more for pregnant women. Okay, severity of the illness is high for pregnant women. Okay, so what is the most common symptom? Only 26% of them actually become symptomatic, right? What is the most common symptom? Is it cough? What's your answer? Make a guess. Is it cough? No, it's not cough. Okay, remember, most common symptom is fever. Most common symptom is fever. Most important MCQ, most common symptom is fever. Second most common symptom is cough. Okay, second most common symptom is cough. Most common symptom is fever. Okay, apart from fever and cough, what else can the lady present to you with? Other symptoms. Okay, the lady can present with diarrhea. She can present with diarrhea. She can present with breathlessness. And of course, she can also present with anosmia. Loss of taste, loss of smell. Okay, both. Okay, or anosmia, loss of smell, and loss of taste also. Okay, she can present with all these. She can also present with myalgia. She can present with non-specific symptoms like arthralgia, vague symptoms also. Okay, the MCQ point is this, which is the most common symptom. The most common symptom is fever. Most common symptom is fever. Second most common symptom is cough. Okay, not all infected pregnant women are symptomatic. Only 26% of them are symptomatic. The remaining 74% of them are asymptomatic. So coming to the severity of the illness. Okay, so I told you, once the woman becomes symptomatic, among the 26% who become symptomatic, the severity of the symptoms, so the severity of the illness is more for a pregnant lady than a non-pregnant lady. Okay, so what do I mean by severity? The number of women who develop hypoxia, the number of women who develop multi-organ failure, the number of women who require ICU admission, all these are high during pregnancy when compared to a non-pregnant lady. Okay, so what all are high? Number of women requiring ICU admissions. Number of women becoming breathless. Okay, women getting breathless. Okay, and multi-organ failure. All these are high during pregnancy. Very important MCQ. All these are high during pregnancy than for a non-pregnant lady. Okay, so complications are more once the woman becomes symptomatic. Okay, so next question is, which trimester is the most vulnerable period? Is it the first or the second or the third trimester? Because we do have different viruses which, cause symptoms at different gestational ages. Say, for example, rubella. When is rubella infection more severe? Tell me, which trimester does it mainly involve, or which trimester does it cause more damage? In which trimester does it cause more damage? First, second or third? Rubella. In the first trimester, right? First trimester, it can cause abortion. first trimester rubella infection can lead to abortion. Okay, it can lead to anomalies. You know, there are certain anomalies like say cardiac anomaly, sensory neural hearing loss, cataract. All these are anomalies related to rubella infection in the first trimester, right? Yes. Chickenpox, tell me. Chickenpox. Students, tell me chickenpox. Which trimester does it frequently involve? I'm asking. Chickenpox, or in which trimester is it more dangerous? Chickenpox or varicella infection? Yes. I hear many of you telling first trimester. Yes. No. Chickenpox is more dangerous when it involves the early second trimester. That means between 13 and 20 weeks. Okay, that is when it causes maximum damage. Chickenpox infection. Rubella causes maximum damage in the first trimester. Chickenpox causes maximum damage in the early second trimester between 13 and 20 weeks. Okay. So now coming to our topic now, we're talking about coronavirus, right? So coronavirus, when does it cause more damage or when does it lead to more complications? When it involves pregnant women in the third trimester. Okay. The severity of the disease is more during third trimester. Okay. The severity of the disease is more in the third trimester. So this again can be taken as a potential MCQ. Which trimester is the most dangerous? Third trimester is the most dangerous, a potential MCQ. Okay. Now next MCQ here. What is the median age at diagnosis? Median age at ICU admission. Okay. The median age at ICU admission is 34 weeks. The median gestational age at ICU admission is 34 weeks. 34 weeks. Okay. So third trimester is the most vulnerable period. Okay. I'm not telling women in the third trimester get infected frequently. Okay. The rate of infection is the same as for non-pregnant lady. That means trimester does not really matter when it comes to the rate of infection. Okay. So what is the importance of this third trimester? It only influences the severity of the disease, I'm telling. If the lady gets infected in the first trimester, the disease would usually go unnoticed. Okay. If she gets infected in the second trimester also, most of the time the disease would go unnoticed. Okay. It would go silent. But if she gets infected in the third trimester, she's more likely to develop a symptomatic disease. And if at all she develops a symptomatic disease, it is more likely to end up in complications. You understand my point? Okay. So this is the importance of trimester. So remember, 2 MCQs, one is third trimester and the other one is 34 weeks. Okay. The gestational age at which she develops maximum complications or maximum ICU admissions, that is 34 weeks. Okay. So what are the effects of pregnancy? The coronavirus, effects of the coronavirus on the pregnancy and the fetus. What does it do to the fetus? Okay. We'll see now. So we have few important MCQ points here. The first and the most important question here is about the teratogenicity of coronavirus. Is coronavirus teratogenic? Does it lead to anomalies, especially if the infection occurs in the first trimester? Because we all know any infection that involves a fetus in the organogenesis period. Organogenesis period means in the first trimester, that means between 3 and 8 weeks, is likely to cause anomalies, right? So here, if we're talking about coronavirus in pregnancy, does it lead to anomalies? Is it teratogenic? That's the most important question. So why am I talking about teratogenicity? Because we know there are certain viruses which are teratogenic, right? So corona infection being a viral infection, there are possibilities that it would lead to anomalies like say rubella, chickenpox, herpes. All these are teratogenic, right? Yes? Name some teratogenic viruses. Name some teratogenic viruses. Doctors, come on. Name some teratogenic viruses. Yes. When I say teratogenic virus, the first thing that should come to your mind is rubella. Rubella. When I say vertical transmission, what comes first to your mind is HIV, obviously. Even though HIV is not the virus with maximum infection, but the maximum rate of vertical infection, HIV is the worst thing that a baby can have, no? Yes? So, yeah, when it comes to teratogenicity, the first virus that should come to your mind is rubella. Name some other teratogenic viruses other than rubella. Chickenpox, varicella. Varicella is again teratogenic. It causes anomalies. It causes scarring of the skin. It causes limb hypoplasia. Yes? Varicella. Few more? Yes? Cytomegalovirus. Correct. Cytomegalovirus. CMV. Yes, teratogenic. Correct. How many of you said parvovirus? Parvovirus. Parvovirus is also a teratogenic virus. Though it does not cause anomalies as much as rubella does, it causes certain unique, complications like fetal anemia. It destroys the RBC precursors in the bone marrow. Okay, parvovirus destroys the RBC precursors in the bone marrow and it leads to fetal anemia. Okay, and in fact, this is the most common infectious cause of fetal anemia. Parvovirus is the most common infectious cause of fetal anemia and it can lead to hydrops fetalis. So these are some examples of teratogenic viruses. Rubella, varicella, cytomegalovirus, parvovirus, all these are viruses which can lead to anomalies. Okay, but there are certain viral infections which can spread from the mother to the baby through the placenta, but they are not teratogenic. Okay, so these are teratogenic. Teratogenic means anomalies. Viruses which cause fetal anomalies. Okay, there are certain viruses which do not cause anomalies. They cause congenital infection, but they do not cause anomalies. Non-teratogenic viruses. Name some non-teratogenic viruses which can spread from the mother to the baby, but still they don't cause anomalies. Yes, non-teratogenic viruses which can spread through the placenta. Yes, HIV, you're correct. I know you're telling HIV. Correct. HIV spreads from the mother to the baby, but it does not lead to anomalies. It can lead to abortions, okay, but it does not have this teratogenic property, okay, it doesn't lead to anomalies. Okay, what comes next? Yes? Correct, hepatitis, okay, hepatitis again, hepatitis B virus again spreads from the mother to the baby through the, yes, placenta. Vertical transmission is possible and in fact the rate of vertical transmission with hepatitis is much more than HIV, but still it does not lead to what? Anomalies like how rubella or varicella do. Okay, so hepatitis B, and to this list now you can add what? Coronavirus. Okay, to this list you can now add corona. Okay, coronavirus. Okay, so HIV, hepatitis and corona are viruses which spread through vertical transmission, but they do not cause anomalies. Okay, so no teratogenicity here, no teratogenicity. Does it lead to abortion? Does it lead to abortion? No, it does not lead to abortion. Okay, so no abortions have been reported due to corona infection until now. Okay, so tell me some infections, viral infections which lead to first trimester miscarriage. First trimester miscarriage, yes? Rubella can lead to first trimester miscarriage, yes or no? Yes, it can. Varicella can lead to first trimester miscarriage, yes, possible. HIV can also lead to miscarriages, okay? So, HIV can also lead to miscarriages. So, a virus which is not teratogenic can also lead to miscarriages, but coronavirus has not been found to cause miscarriages until now, okay? So, it does not lead to miscarriage. Intrauterine growth retardation, it does not lead to IUGR. Okay, what can lead to IUGR? Tell me some congenital viral infections which can lead to IUGR. Again, yes, rubella. Rubella can lead to intrauterine growth retardation. Yes, varicella can lead to intrauterine growth retardation. Okay, so cytomegalovirus can lead to intrauterine growth retardation. But coronavirus has not been found to cause intrauterine growth retardation till now. Okay, it does not lead to intrauterine growth retardation. It neither leads to IUGR nor it leads to stillbirth. Okay, nor it leads to stillbirth. Okay, so this virus, coronavirus, is not a teratogenic virus. It does not lead to abortions. It does not lead to IUGR. It again does not lead to what? Stillbirth. Okay, so these complications are not associated with COVID infection in pregnancy. So what else does it really do? What else does it really do, or what does it cause? Okay, I'll tell you. Preterm birth. Yes. So COVID infection, does it lead to preterm birth? My answer is, remember, the incidence of preterm birth is high. The incidence of preterm birth has increased with COVID infection in pregnancy. Okay, the incidence of preterm birth has increased with COVID infection in pregnancy, but it has not been proven that the virus itself is responsible for this preterm birth. Rather, woman develops hypoxia. This hypoxia, secondary to the maternal hypoxia, the fetus also develops hypoxia, and that is how the process of labor begins and the baby, delivers preterm. Okay, or we can say the woman succumbs in the third trimester. Say she gets infected at 30 weeks or 32 weeks. She, develops breathlessness. She develops, hypoxia. And because of that, we are forced to deliver the baby preterm. And the woman, when the maternal condition is so bad, we may not be able to continue pregnancy, right? When there is multi-organ failure, or when there is shock, when there is severe respiratory distress, we may not be able to continue the pregnancy. I'll tell you where to terminate the pregnancy. For now, you listen. Okay. So when complications arise, in order to save the mother, we would be forced to deliver the baby preterm, and that is how the incidence of preterm delivery increases with COVID, not as such due to the fetal infection due to coronavirus. You understand? It is not due to the fetus getting infected with COVID. It's only due to mother getting infected with COVID, and not to save the mother, we would deliver the baby fast. Okay. So preterm birth, the incidence increases due to COVID infection. Okay, but most of them are, as I told you, most of them are what? Iatrogenic. Most of them are iatrogenic. So iatrogenic means what? We induce labor and we deliver baby preterm in order to save the mother. Okay, so what's the incidence of cesarean birth? Like whether the incidence of cesarean has increased in women infected with COVID? Yes or no? Yes. What has happened? The incidence of cesarean birth has actually increased in women with COVID infection. Okay. Again, why? Again, for the same reason. Woman develops hypoxia. Once she gets infected in the third trimester, yes, she gets infected in the third trimester. If she becomes symptomatic, the symptoms progress rapidly, and at one point the woman develops hypoxia. And any hypoxic woman would not be able to push during delivery, right? She would not be able to, tolerate the stress of labor. Yes. So, due to these reasons, though there is no direct indication for cesarean section in this lady, because of hypoxia, because of the decreased maternal efforts, the obstetrician would be forced to do a cesarean section, to perform a cesarean section. As such, COVID infection is not an indication for cesarean section. You understand? So, yes, it increases. Cesarean birth has increased since this COVID pandemic has started. Okay. And the need for general anesthesia has also increased. Need for general anesthesia. Usually, we don't prefer giving general anesthesia to a pregnant lady, right? For cesarean section, we prefer giving regional anesthesia. We prefer giving spinal anesthesia, at times epidural anesthesia, even for some heart disease. So, we rarely use general anesthesia during pregnancy, especially for cesarean section, only when it is, strictly indicated. Fine. Here, the need for general anesthesia has increased due to women succumbing to, multi-organ failure or hypoxia or severe respiratory distress, where she's not able to tolerate the regional anesthesia and she wants mechanical ventilation. So that's when we do a cesarean section under general anesthesia, and as such, we don't give general anesthesia for all women infected with COVID-19. We only give it whenever the woman needs it. That means whenever she's severely hypoxic and she needs intubation. Okay. So the need for general anesthesia has increased. So what were the effects of COVID-19 on the fetus? COVID infection is not teratogenic. It does not lead to miscarriage. It does not lead to IUGR. It does not lead to stillbirth. It has increased the preterm births. It has increased the rates of preterm deliveries. It has increased the rates of Cesarean section, and it also has increased the need for general anesthesia. Okay, fine. So next question here. Is COVID infection an indication for termination of pregnancy? Is it an indication for termination of pregnancy? Should we abort the baby if the lady gets infected in the first trimester? Answer is a big no. This is not an indication for termination of pregnancy. Okay. So tell me one indication, one infectious indication for termination of pregnancy. One infection where if it occurs in the first trimester, you will terminate the pregnancy. Come on, students. Rubella. Okay. Rubella infection in the first trimester. Rubella infection in the first trimester is an indication for termination of pregnancy. Fetal infection, okay. So, rubella infection in the first trimester usually leads to anomalies. The anomaly rate is very high, and therefore, rubella infection in the first trimester is an indication for termination of pregnancy, okay. So, when you compare this coronavirus with rubella, you understand that coronavirus is not teratogenic, whereas rubella is teratogenic, and coronavirus infection does not naturally increase the chance of miscarriage. Neither it increases the risk of miscarriage, nor it becomes an indication for miscarriage. Okay. So, COVID infection is not an indication for termination of pregnancy. Okay. So, next we'll discuss about risk factors. Risk factors. Okay. So, what are the risk factors here? Please remember, being an Asian itself is a risk factor. Asian women are at risk for severe corona infection. Asian pregnant women are at risk for severe corona infection than, European women or white Western women. Okay. So, Asian women, fine. So, next important risk factor is the gestational age. As I already told you, which trimester? Women in the third trimester are at increased risk. Women in the third trimester are at increased risk. Okay. Next important predisposing factor or risk factor is vitamin deficiency. Especially which vitamin? Vitamin D deficiency. Okay. Deficiency of vitamin D increases the risk of corona infection. Okay. Next is age more than 35. Okay. Pregnant woman aged more than 35 years. Okay. Yes. Then very, very important MCQ point is this. Okay. Women with heart disease. Women with what? Heart disease. Pregnant women with heart disease are at increased risk of developing severe corona illness. Okay. Pregnant women with heart disease are at increased risk of developing what? Severe corona illness. Okay. So, very important MCQ, and in fact, this is the most dangerous combination. Pregnancy, heart disease and COVID infection. This is the most dangerous combination that would easily, collapse the mother. Okay. So, Asian population, third trimester, vitamin D deficiency, age more than 35 and heart disease. Apart from these, other general risk factors like obesity, diabetes, bronchial asthma, all these are applicable during pregnancy too. Okay. So, we do have other risk factors like obesity, medical illness. So, what medical illness am I talking about? I am talking about diabetes. Yes. I am talking about asthma, bronchial asthma, or whatever, like say renal failure or whatever. All these increase the severity of illness during pregnancy, and these are considered high risk factors during pregnancy. And in particular, I want you to remember 2 MCQ points here. What are they? Number 1, vitamin deficiency, vitamin D deficiency, and number 2, heart disease. Okay, vitamin deficiency and heart disease increase the severity of corona illness during pregnancy. So next is on antenatal care. Antenatal care. Okay. So, how to plan the maternal antenatal visits? how to alter it for a COVID patient. Okay. So, can antenatal services be denied in order to test for COVID-19? What's your answer? Give me your answers. Can antenatal services be denied in order to test for COVID-19? Say, for example, you have a 28-year-old primary gravid lady and she comes at 38 weeks of pregnancy. Okay, she comes at 38 weeks of pregnancy with pains, with labor pain. She's in labor, okay, and she has good contractions. Say she is in the latent phase of labor, okay, but she says she has cough for 2 days. Since last 2 days, she's been having cough, okay, but she has not been tested for COVID yet, okay, and now she's rapidly progressing, and from the latent phase, she's entered into the active phase. So once she is into the active phase, definitely she requires admission, right? You can't send her home. She is in the active phase now, but she's had cough since the last 2 days and she's not been tested for COVID yet. Okay, what would you do in this situation? In this situation, just because she doesn't have a COVID report, just because she's not been tested for COVID, would you send the patient home? Would you deny admission? Would you deny hospital services or, institutional delivery for this patient? No, not at all. No woman should be denied, okay, antenatal services, intrapartum services in order to test for COVID-19. Admit, simultaneously test. Until the report comes, you consider her to be a confirmed case of COVID positive until she's proven to be negative. Okay, you isolate her and treat her in a separate ward until the report comes. Okay, and you need to have a separate ward for these women who come with symptoms but are yet to be tested. Okay, so antenatal services should not be denied. Antenatal services should not be denied in order to test for COVID-19 infection. All women coming with symptoms should be tested. Okay, definitely they should be tested, and if they require emergency antenatal services or emergency intrapartum services, they should be admitted and simultaneously the testing should take place. Okay, fine. So, supposing say you have a patient for whom you suspect COVID infection and you have confirmed her to be a positive case, okay, or she is living in a place where there are more COVID cases and you want to limit the number of visits. How would you limit the number of visits? What are the ideal number of visits or the minimum number of visits? Okay, so say here the minimum number of visits would be 4. Minimum number of visits should be 4. Okay, 4. Okay, so when all will you ask the patient to come? You'll ask the patient to come at 12 weeks, 20 weeks, 28 weeks and 36 weeks. So, you'll ask the patient to come at 12, 20, 28 and 36. Okay, these 4 visits the lady shouldn't miss. Okay, she shouldn't miss. Other visits are optional. In case there are so many COVID patients in the hospital that she is frequently going to, then she may not like to go there. She might prefer getting home consultation or, teleconsultation. In that condition, the woman should be allowed to take teleconsultation except for these 4 visits, like say 12, 20, 28 and 36, where she will have to, come to the hospital and get her vitals as well as her, abdomen and all necessary parameters checked. Okay, so these are the 4 mandatory visits: 12, 20, 28 and 36 weeks. Okay, and regarding the elective procedures means say induction of labor. Okay, so can we do during this COVID time? Yes, elective procedures should be avoided or decreased, decreased as much as possible. Okay, elective procedures should be avoided or decreased as much as possible to decrease the overload to the hospital. Okay, so minimum antenatal visits are 4. Okay, and those visits should be placed ideally at 12, 20, 28 and 36 weeks. Okay, so this is about antenatal visits. Okay, Next, we'll discuss about thromboprophylaxis. Thromboprophylaxis. So, once a lady is infected, once an antenatal mother gets infected with COVID, is she a candidate for thromboprophylaxis? Should you put her on heparin? What's your answer? Should you put her on heparin? The drug of choice will be low molecular weight heparin, right? Low molecular weight heparin. Is COVID-19 infection during pregnancy an indication for heparin? The answer is yes, yes. Okay? Yes, we have to. We have to put her on heparin. Okay? Yes, we have to put her on heparin. Pregnancy is a hypercoagulable condition, a procoagulant condition, yes or no? Pregnancy is a prothrombotic state. Pregnancy is a prothrombotic state. Pregnancy is a hypercoagulable condition. What's your opinion? Is it true or false? Pregnancy is a prothrombotic state. True or false? Yes? Yes, doctors? Pregnancy is a prothrombotic state. This statement is absolutely true. Pregnancy is a prothrombotic state. Okay? And you all know COVID infection itself increases the risk of thrombosis. Yes or no? Yes, COVID infection itself increases the risk of thrombosis. When there is already a prothrombotic state in the body, and that is pregnancy, this COVID infection is a super added condition where the risk of thrombus is much increased. Yes or no? Yes, the risk of thrombus increases. The risk of thrombus increases with what? With COVID infection during pregnancy. Okay, the risk of thrombus increases with COVID infection during pregnancy because pregnancy itself is a prothrombotic state. So what would we do? We have to put the patient on heparin, okay? But remember, there are certain important MCQ points which you have to know in this. Point number 1, if the patient is under home isolation, the patient has to hydrate herself, okay? The only thing that is required here is hydration, okay? The only thing that is required here is what? Hydration, okay? Now, in case the patient is admitted in the hospital, okay? In case she is admitted in the hospital, she will require low molecular weight heparin, the injections, okay? Injection low molecular weight heparin. If the patient was taking heparin for some other reason, if she is already on heparin for some other reason, if she is already on heparin, okay? Say she is a case of recurrent pregnancy loss, or she is a case of antiphospholipid antibody syndrome, or for any other indication like say prosthetic valve, she is already on heparin. The patient should not stop heparin during pregnancy and she has to continue this heparin. Continue the same dose of heparin, okay? Continue the same dose of heparin even during pregnancy, even during COVID infection, okay? But in case the woman was not already on heparin, she is a normal pregnant patient, she is not on any heparin and she has developed what? She has developed COVID infection now, okay? In that case, what would you do? COVID infection in the antenatal period, COVID infection during the antenatal period, start her on heparin, okay? Start what? Start low molecular weight heparin and give for how long? You need to continue this heparin until she recovers and even thereafter, and this has to be continued for at least 10 to 14 days from recovery, okay? Not from the time of diagnosis but from the time of recovery. Recovery means from the time she becomes swab negative, okay? So, start low molecular weight heparin and continue for at least how many days? Continue for at least 10 days after recovery. 10 days after recovery. Okay. continue for at least 10 days after recovery. So this becomes an important MCQ, at least 10 days, ideally 14 days. Okay, ideally 14 days, at least 10 days from diagnosis or from recovery? Recovery. Okay, so say you diagnosed her today and she say symptomatic for another 1 week and she becomes RT-PCR negative after 1 week. So you will continue it for another 10 days. So that becomes 10 days plus this 1 week. So totally it will come to around 17 to 20 days. Okay. In the postpartum period, if the lady gets infected in the postpartum period, okay, if the lady gets infected in the postpartum period, again remember you have to start her on heparin. Okay, you have to start her on heparin. And again, you have to continue this heparin for 10 to 14 days, at least 10 days, okay, ideally 14 days. Continue this heparin for at least 10 to 14 days from the time of recovery. Okay, so this is about thromboprophylaxis during pregnancy in COVID infection. Okay, so regarding isolation and home quarantine, okay, for how long should the woman be isolated at home and for how long can the antenatal appointments be deferred? Okay, so once the patient has developed symptoms, okay, for any symptomatic lady, for any symptomatic pregnant lady, appointments can be deferred until 7 days after the start of symptoms. Okay, appointments can be deferred until 7 days after the start of symptoms. Okay, this is for someone who is tested COVID negative. Okay, if she's been tested COVID positive, then the ideal isolation period should be 14 days. Okay, she's developed symptoms just of COVID and she's not got tested or she's been tested negative, then at least you would defer it for 7 days from the start of symptoms. Now, in case the woman is not tested positive, but she's been exposed to her household with COVID, okay, as say someone at home, say her husband or in-laws or someone developed COVID, and in case she's exposed, what should be the ideal quarantine protocol? Remember, there should be self-quarantine in case of exposure at home, okay, in case of exposure at home with some household members, the lady has to go on self-quarantine for 14 days. And here appointment should be deferred for 14 days. 14 days from the time of exposure. 14 days from the time of exposure. So I think you understand the difference between the previous statement and the second statement. Okay. In the previous statement, she has had no significant exposure, but she has certain symptoms suggestive of COVID infection, but she's not been tested positive. In that case, owing to the possibility of this lady having COVID, we would put the patient on quarantine, or we would not allow her to attend the antenatal OPD for at least 7 days from the start of symptoms. Okay. But in case she has significant exposure and she's not developed any symptoms or she's not been tested for COVID, in that case, you will put the patient on quarantine, self-quarantine for 14 days, and all appointments, antenatal appointments deferred till then. Okay. And in case the patient herself has been tested positive for COVID, the guidelines are, separate, which we will be discussing. Okay. For someone who has been tested positive for COVID, we will discuss on what to do. This is what we will be doing for women who have not been tested positive, for women who have developed symptoms without having a COVID positive test, or for someone who has exposure at home, who has been exposed to COVID virus at home, but she's not developed disease yet. Okay. And also remember, antenatal ultrasound. Say for example, if she has to get one ultrasound at 20 weeks, her targeted scan or anomaly scan at 20 weeks, and 2 or 3 days prior to the actual date for scan, she developed symptoms or she developed COVID illness. Okay, what would you do? The scans can be deferred for at least 14 days from her positive test. Okay, so from her due for the scans, that means if she develops positive test 1 or 2 days prior to her due for the scan, she can postpone the scan for at least 14 days, okay, from the positive status, okay. So, this is about isolation and quarantine. So, we'll discuss about labor management, okay. Now, the first question to you, is COVID infection an indication for induction of labor? Is COVID infection an indication for induction of labor? Say a lady comes at 32 weeks of pregnancy, she develops COVID illness, okay. She develops symptoms due to COVID infection, fine. Now, just because she's developed symptoms, should you terminate the pregnancy? I'm asking. Just because she's developed symptoms, should we terminate the pregnancy? She has cough, she has fever, so should we terminate the pregnancy for this reason? Answer is no. No, we need not terminate the pregnancy until she develops complications, okay. Unless and until she develops complications, we need not terminate the pregnancy, okay. So, treat only the infection, don't terminate the pregnancy. But there are certain conditions where you would prefer terminating the pregnancy in order to save the mother, okay, because recovery is, not very fast in a pregnant lady, whereas recovery is fast in a non-pregnant lady. So, you would consider terminating the pregnancy to hasten the recovery, okay. So, where would you consider terminating the pregnancy, okay? When there is severe, okay, when there is severe failure criteria, you would consider terminating the pregnancy when there is severe failure criteria. So, what are the indications for termination? What are the indications for termination of pregnancy? The indications for termination of pregnancy are number one, septic shock. Okay, the indications for termination of pregnancy are number one, septic shock. Okay, number two, acute organ failure. Number two, acute organ failure. Okay. And number three, GCS score of less than 15. Okay. Number three, GCS score of less than 15. Okay. So, these are the three indications for termination of pregnancy regardless of the gestational age. If you terminate before 24 weeks, it would come under abortion. If you terminate after 24 weeks, it would come under preterm labor provided she is not 37 weeks yet. Okay. COVID infection as such is not an indication for induction of labor. COVID indication as such is not an indication for cesarean section unless the patient develops complications. Okay. So, what complications become indications for termination of pregnancy? What complications are indications for termination of pregnancy? Okay. Number one, septic shock. Number two, acute organ failure. And number three, a GCS score of less than 15. Okay. A GCS score of less than 15. So, I request you to remember this MCQ. This is what the ICMR suggests. Okay. When to terminate the pregnancy? Only under these three conditions, or otherwise termination of pregnancy. COVID infection is not an indication for termination of pregnancy. So, next question to you, is COVID infection an indication for cesarean section? Is it an indication for cesarean section? Say you have a patient at 39 weeks. 39 weeks. Okay. She goes into spontaneous labor. Okay. She develops pain. Okay. But she's been tested positive for COVID. Okay. She's been tested positive for COVID and she is in isolation since the last 3 days. Okay. She is under home isolation since the last 3 days because the infection was mild. Okay. She had mild symptoms, mild cough, mild fever, and she's been put on home isolation for 3 days. What would you do in this case? She's developed pains now. She's entered into labor now. But she's been tested positive for COVID. Come on, doctors, what would you do? Would you do a cesarean section, I'm asking? Because she is COVID positive. Is COVID positivity an indication for cesarean section, I'm asking? Or you would allow her to progress? What would you do? She has only mild illness, but still she has the infection. Yes, she is extremely contagious. Even though she has only mild illness, you can't say that people who get exposed to the infection from this source would develop only mild illness. She can, yes, spread. She can, yes, give the infection to all other healthcare workers. And in that case, what would you do? Perform a cesarean section on her or allow her to progress and deliver spontaneously. COVID infection is not an indication for cesarean section. Okay, COVID infection is not an indication for cesarean section. Not an indication for cesarean section. Okay, cesarean section should be performed only for obstetric reasons. Only for obstetric reasons. That means she has placenta previa or she has malpresentation or there is some other indication for cesarean, only then you will do what? Cesarean section. Only for obstetric indications, not for COVID reasons. Okay, not for COVID reasons. Tell me some infections where you would preferably deliver by cesarean section. Some infections where you would preferably deliver by cesarean section, and also tell me why. Tell me one indication, one infectious indication for cesarean section. What comes to your mind first? One infection where you will do cesarean section. Yes? HIV. Won't you do a cesarean section for HIV infected woman? Yes. Yes, we would prefer doing a cesarean section for HIV infected woman provided the viral copies are more than 1000. Yes? Preferably cesarean section. Okay. Hardly in 1 or 2 cases where the viral load is very less and the woman demands for vaginal delivery, you would prefer doing a vaginal delivery, or otherwise you would actually perform a cesarean section. No? Yes, for HIV infected woman. Why? Why? Why for HIV you prefer doing a cesarean section and why not vaginal delivery? Tell me why. Why do you prefer doing a cesarean section for HIV infected woman and why not vaginal delivery? Yes? The main reason is because HIV is secreted or the virus is present in high quantities in vaginal secretions. Vaginal secretions. Okay. The virus is present in high quantities in vaginal secretions. Okay. So you don't want the baby to get exposed to the mother's vaginal secretions. And for this reason, you don't see, the more the exposure, the more the transmission. If the patient is in labor for say 10 hours or 20 hours, what might happen for 10 or 20 continuous hours after the rupture of membranes? If she's staying in labor for another 4-6 hours, in this 4-6 hours, she might get exposed to the vaginal secretions and the rate of transmission would actually increase. Okay, either you don't want the baby to get exposed to the maternal vaginal secretions and you want the labor to be as quick as possible and therefore you deliver by cesarean section. Okay, tell me one other example where the virus is shed in the vaginal secretions and therefore you don't want the baby to get exposed to this. Yes, one other infection, viral infection where the woman develops lesions in the genital tract. Lesions in the genital tract, lesions in the labia, blisters, vesicles in the labia. What is that? Yes, herpes. Herpes. Okay. Active genital herpes. Active genital herpes. In case the mother has active genital herpetic lesions, would you encourage vaginal delivery? Would you encourage vaginal delivery? No. Why? Because the vesicle that the lady develops with herpes infection is rich in what? The virus. Is rich in virus that causes herpes, the herpes virus. Okay, the HSV, herpes simplex virus 1 and 2, they are rich. They are present in high quantities in the vesical fluid. Okay, so you don't want the baby to get exposed to this virus during a vaginal delivery and you prefer doing a cesarean section. Okay, but here in COVID, please remember, we have not yet found the virus to be present in the vaginal secretions. Okay, coronavirus has not been detected. Coronavirus has not been detected in the vaginal secretion as well as breast milk. Okay, vaginal secretion as well as what? Breast milk. Okay, it is not proven to be present in either the vaginal secretion or the breast milk, and therefore getting exposed to the vaginal secretion would not actually increase the risk of transmission to the baby, and that is why COVID infection is not an indication for cesarean section. Okay, but still at times you would perform a cesarean section for some other reasons, like say the woman develops severe hypoxia. She's not able to push. The woman's saturation drops to that extent that she requires intubation. Okay, in that case, obviously you'll have to do a cesarean section. Okay, obviously you will have to perform a cesarean section. So only for those women who are not able to cooperate for vaginal delivery, only for those women who require general anesthesia for other reasons, only for women who require intubation, and only for women who succumb to hypoxia, you would be performing a cesarean section and not routinely. Okay, I hope you all understand. Yes. So COVID infection does not spread through the vaginal secretions. It does not spread through the vaginal secretions. Okay, fine. So little more details on how to conduct the delivery. The first one is birthplace. Okay, all COVID infected women should preferably deliver in a tertiary care hospital. Okay, preferably where? Preferably in a tertiary care hospital. Okay, preferably in a tertiary care hospital. Okay, and all symptomatic women should be monitored with continuous electronic fetal monitoring. Continuous electronic fetal monitoring means what? Continuous CTG, cardiotocography. We have two probes in cardiotocography, right? One probe over the fundus to monitor the contractions, and other probe over the fetal heart to record the fetal heart rate. Yes, so continuous CTG monitoring should be done for all symptomatic women. For asymptomatic women, intermittent monitoring can be done. Okay, for asymptomatic infected women, intermittent monitoring can be done. For all symptomatic women, continuous electronic fetal monitoring should ideally be done. Okay, so how often would you check the vitals? Vitals should be checked hourly. Okay, vitals should be checked hourly, and this includes temperature, pulse rate, respiratory rate, and urine output. Okay, temperature, pulse rate, respiratory rate, and urine output should be checked hourly. Okay, analgesia. What is the preferred analgesia? Yes, the preferred analgesia is actually epidural. Preferred analgesia is actually epidural. So regional analgesia. Okay, regional analgesia. But still, Entonox can also be given. Entonox can also be given. The disadvantage is that when we give Entonox, we use face masks, Entonox. So it helps in spread of the infection actually. But the current guideline says with single patient filters, single use filters, okay, Entonox can be safely given. Easy to administer. Entonox is easy to administer. It does not require much expertise. But epidural requires much expertise. You need an anesthetist to give epidural analgesia, and therefore some people would prefer Entonox. But for exams, the best answer is epidural analgesia. Okay, so what is the best answer for exams? Epidural. The preferred mode of analgesia during labor for COVID infected pregnant women is epidural analgesia. Okay. Oxygen saturation. So oxygen saturation should be maintained above. What's your answer? Give your answers. Come on. Oxygen saturation should be maintained above 94%. Okay. Oxygen saturation should be maintained above 94%. 94%. Okay. And second stage. What would we usually do to the second stage in case of heart disease? In case of severe anemia, heart disease, in case of fetal distress, what would you do to the second stage? Tell me guys, what would you do to the second stage? Second stage is when the cervix is fully dilated, means the time gap between full dilatation and delivery, How do we cut short the second stage? In preeclampsia, in heart disease, how do we cut short the second stage? Yes, instrumental delivery, Yes, we use instruments like forceps or vacuum. We use instruments like forceps or vacuum to cut short the second stage of labor in severe preeclampsia, in heart disease, and severe anemia, wherever we don't want the patient to stress, wherever we don't want the patient to push, wherever we don't want the patient's heart rate to increase. We would prefer doing what? Instrumental delivery, yes or no? Here again, for women who are hypoxic, okay, for women who are hypoxic, for women who are not able to push, for women who are not able to push, what would you do? Instrumental delivery. So, not for all women, but for women who are really sick, okay, for women who are really sick and really finding it difficult to push, for women who are hypoxic, yes, instrumental delivery can. If the lady is not able to completely breathe and if the lady is already under intubation, then she is a candidate for cesarean section. That's completely different. But if she is not as bad as a ventilated woman, say she is able to manage her saturations and she does not require intubation, but still when she pushes, she develops more breathlessness. She is not able to push and she develops hypoxia, but still she is not under, intubation. In that case, you will do what? Instrumental delivery, okay? Either forceps or vacuum, okay? Yes? Next is about birth partners. Birth partners. So, usually we allow birth partner. One birth partner is allowed to be with a mother, right, during delivery. So, here again, yes, one asymptomatic negative partner can be allowed. One asymptomatic COVID negative partner can be allowed to be with a woman for her emotional support, okay, and the partner who is with the patient should be wearing what? Yes, personal protective equipment, okay, she should be wearing PPE, okay. So, last question on labor management, we have certain invasive procedures like fetal blood sampling and fetal scalp electrode monitoring to see if the baby develops hypoxia, okay. Fetal blood sampling, we usually do it in cephalic presentation. From the head, we take, little blood and see the fetal blood pH, okay, fetal blood pH to see if the baby is developing lactic acidemia, okay. So, can we perform those sampling procedures here in a COVID infected pregnancy? Answer is again, yes, we can, okay. Where should we avoid doing this fetal blood sampling? Whenever we don't want the baby to get exposed, whenever we don't want the baby to get exposed to the maternal secretions or the maternal amniotic fluid, whenever the risk of infection is high when the baby is exposed to the amniotic fluid or the secretions, we avoid doing fetal blood sampling. Give me one example. Give me one example where the transmission is through vaginal secretions or the amniotic fluid. Yes, I just told you now. Yes, HIV, hepatitis, herpes. Yes, all these can spread from the vaginal secretions. So, once you make a laceration on the fetal head, yes, the transmission of the virus becomes easy, okay. But here we have no such transmission, okay. So, fetal blood sampling can be done. Fetal blood sampling can be done. Fetal scalp electrodes can be fixed to see if the patient to see if the baby develops hypoxia during labor, okay. So, all these can be done. So, these are the points under labor management, okay. So, I'll quickly tell you, COVID infection is not an indication for induction of labor unless the mother develops complications like septic shock or, organ failure, okay. COVID infection is not an indication for cesarean section because COVID infection does not spread through vaginal secretions, okay. The virus has not been detected in vaginal secretions yet, okay. So, preferably deliver in a tertiary care hospital. For all symptomatic women, put them on continuous electronic fetal monitoring, and for asymptomatic women, intermittent electronic monitoring, okay. Early vitals monitoring. And the preferred mode of analgesia is epidural analgesia. Epidural analgesia. Maintain the oxygen saturation to more than 94%. Okay. Cut short the second stage with instruments like forceps or vacuum only for hypoxic women who are symptomatic, women who are breathless. Okay. Allow one birth partner who is asymptomatic and COVID negative. Okay. Fetal blood sampling can be done. Fetal scalp electrodes can be fixed. Okay. So, a small algorithm on the management of COVID in pregnancy. Management of COVID in pregnancy. Okay. So, what would you do first? See whether the patient is symptomatic or asymptomatic. Okay. For all pregnant women with suspected COVID-19. Okay. With suspected COVID-19, we call them PUI. Okay, PUI. What is PUI? PUI is pregnant woman under investigation. PUI is pregnant woman under investigation. Pregnant woman under investigation. Okay. Pregnant woman under investigation means a lady who has developed symptoms, or a lady who is exposed, a lady where the household people have developed COVID infection. Okay. All susceptible women, or all women under, investigation. Okay. I divide them into two groups. One is asymptomatic, and the other one is symptomatic. Asymptomatic and symptomatic. Okay. Subject them for COVID testing. RT-PCR. Okay. And depending on the results, we again divide them into, COVID negative, COVID positive. Okay. Again, symptomatic women, I divide them into COVID negative and COVID positive. Okay. Negative, positive. Okay. What would you do for this woman? She is asymptomatic. She is COVID negative. Asymptomatic, COVID negative. We can just stop monitoring here. She is a low risk lady. We can just stop monitoring here. What would you do for this lady? For this lady who is asymptomatic positive, or for this lady who is symptomatic negative. Okay. Asymptomatic positive or symptomatic negative, the management is the same. Okay. Isolation at home for 14 days. Okay. What would you do? Home isolation. Home isolation for how long? 14 days. Home isolation for 14 days. Okay. As long as her vitals are stable. Okay. As long as her saturation is maintained. She should be advised on how to monitor herself, the respiratory rate and the vitals. And as long as she is stable, she can stay at home, isolate herself for 14 days. Why? Because we know 74% of the women are asymptomatic. Among the women who are symptomatic, most of them recover without any complications. Okay. So, home isolation for 14 days. Okay. Until she recovers. Okay. Fine. Now, for a lady who is symptomatic and COVID positive. For a lady who is symptomatic and she is COVID positive. Here only she requires what? Hospitalization. Okay. So, here she requires admission. Here she requires admission where? Admission in a tertiary care hospital. Admission in a tertiary care hospital. Okay. So, hope you all understand. For asymptomatic woman who is positive and for symptomatic woman who is tested negative, just put them on home isolation for 14 days and ask them to self-monitor themselves. Okay. For symptomatic women who is COVID positive, just admit the patient in a tertiary care hospital. Okay. And once you've admitted the patient in a tertiary care hospital, what all should be done? Please remember, the mother has to be monitored for the heart rate, temperature, the heart rate, the blood pressure and the respiratory rate. Okay. At least 4 times a day. Okay. And also remember, mother has to be subjected for a CT scan or chest x-ray as per the routine guidelines. So, tell me doctors, can CT be performed in this patient? Can we do a CT for this patient? Yes or no? What's your opinion? Usually we don't prefer doing a CT, no? In order to avoid, radiation to the baby. Here, yes, we can. Okay, here the guideline says benefits are more than the risks. Benefits outweigh the risk. Okay, and therefore, yes, CT, chest or X-ray can be performed with abdominal shield, with abdominal shield, with abdominal shield. Okay, so the fetal heart rate should again be monitored. This is for the mother. Fetal heart rate should again be monitored. Okay, and what else? Few important MCQ points on how to manage further. Okay, she has to be put on antibiotics. She has to be put on antibiotics. But there are certain MCQ based questions here on whether we can give steroids for the mother, whether we can give steroids for the baby, for the lung maturity of the baby, whether we can put the woman on antiviral therapy, we can start magnesium sulfate for the patient for the neuroprotection of the baby. Okay, all these are MCQ points. And finally, when to terminate. These are the 5 important MCQ points on termination. So, once the lady is found to be COVID positive and she is symptomatic, admit the patient in a tertiary care hospital. After admission, what would you do? After admission, check her vitals, check the baby's heart rate, do a CT scan or chest x-ray as per the routine guidelines. Okay, do not exclude the pregnant lady from CT or chest x-ray. Put her on antibiotics, and after that, okay, antiviral therapy. Now tell me, doctors, can we put the lady on antiviral therapy? What does the current guideline say? Are these antiviral drugs teratogenic? That's my question. Are these antiviral drugs teratogenic? Okay, should we defer giving these antiviral drugs for a pregnant lady? What's your opinion? Yes, can we give? Yes, answer is yes, we can. Okay, antiviral therapy is not contraindicated during pregnancy. Antiviral therapy is not contraindicated during pregnancy. A pregnant woman can be put on antiviral drugs like, say, remdesivir, which we usually give, and the guideline should be the same as for a non-pregnant lady. Okay, antiviral drugs can be given. Okay, so next is aspirin. Okay, if the lady was already on aspirin, most of the pregnant women are on aspirin, no? For some reason, they would be on aspirin, for preeclampsia prevention, or for some other reasons like, say, heart disease or a recurrent miscarriage, they would already be on aspirin. In that case, what would you do with this aspirin? When to stop aspirin? Yes? See, it is better to continue aspirin even during COVID illness, okay, as long as the platelet count is more than 50,000. If the platelet count falls to less than 50,000, if the platelet count falls to less than 50,000, stop aspirin, or otherwise continue. If only the platelet count falls to less than 50,000, stop aspirin or otherwise continue. Okay, so this is one MCQ. Antiviral drug, this is one MCQ. Okay, yes, next question. I already told you about CT and chest x-ray. Can it be done? Yes or no? Yes, CT and chest x-ray can be done during pregnancy. Usually it should be deferred, but here the benefits outweigh the risk. Okay, here benefits are more than the risk. And therefore both the RCOG and the ICMR support the use of chest x-ray and CT for better management of COVID illness during pregnancy, but with abdominal shield. With what? Abdominal shield. Okay, so CT or chest x-ray can be done. Okay, steroids. Can we give steroids for lung maturity? Can we give steroids for the mother to control the COVID illness? Yes, we can. Okay, steroids can be given for the mother and steroids can be given for the lung maturity of the baby. So, what do we usually give for the mother? For the mother, to reduce the severity of COVID illness, we either give methylprednisolone, or we give hydrocortisone in case of emergencies. No, methylprednisolone, or we give hydrocortisone in case of emergencies, right? Okay, but this is not the same as what we give for the baby, for the lung maturity of the baby. For the lung maturity of the baby, what do we give? Here we prefer giving dexamethasone or betamethasone. Here we give dexamethasone or betamethasone. Okay, take it from me, both can be given. simultaneously. Okay, both can be given simultaneously. You start methylprednisolone to decrease the severity of the disease for the mother and simultaneously you put the mother on betamethasone to hasten the lung maturity of the baby. Okay, so both can be given simultaneously. Okay, so chest X-ray can be done, aspirin can be continued as long as the platelet is more than 50,000, antivirals can be given, steroids can be given. Okay, so this is about the management of COVID illness during pregnancy. So, when will you consider delivery? When will you consider delivery? Yes, you will consider delivery if only there is some complication, right? If only there is complication, or otherwise you will not consider delivering. Yes. What are the signs of danger? What are the signs of danger and when will you consider delivering? Okay, the signs of danger are systolic blood pressure less than 100 millimeters of mercury, respiratory rate more than 22 and respiratory rate more than 22 and GCS score of less than 15. Okay, systolic blood pressure of less than 100, respiratory rate of more than 22 and GCS score of less than 15. Okay, so these are the signs of danger. These are the signs of danger and these signs require ICU care. Okay, when the woman has developed any of these, that means systolic blood pressure less than 100, respiratory rate more than 22 and GC score less than 15, more than one of the following. More than one of the following. More than one of the following requires what? ICU care, and this is the quick SOFA score. Okay. What is it called as? Quick SOFA score. This is called as quick SOFA score. Okay. So, what is the indication for termination? When the patient develops severe failure. When the patient develops severe failure, I already told you, no? Severe failure. That means the patient is in septic shock. The patient is in septic shock, or the patient develops acute organ failure. She develops acute organ failure, or she develops fetal distress, or she develops fetal distress. These are the indications for immediate delivery. These are the indications for what? These are the indications for immediate delivery, preferably by Cesarean section. Indications for immediate delivery, preferably by C-section. Okay, so when will you shift the patient to ICU? When will you shift the patient to ICU? If her blood pressure is less than 100, if her respiratory rate is more than 22, if her Glasgow Coma score is less than 15, you will shift her to ICU. When will you consider delivering? Okay, fetal distress, acute organ failure, septic shock. This is when you will consider delivering. Okay, fine. So, the last point on COVID infection during pregnancy is on breastfeeding. Breastfeeding. Okay. So, doctors tell me, does it spread through the breast milk? Does COVID infection spread through breast milk? Yes or no? Does it spread through the breast milk? It is not present in vaginal secretions. It's not been found in vaginal secretions yet. Similarly, it has not been found in breast milk yet. Okay, COVID virus has not been detected in breast milk yet. So, can she breastfeed? Yes or no? Yes, it does not spread through the breast milk as such, but during feeding, the mother brings her baby close to her nostrils. No, she brings the baby close to her nostrils. Yes, so there is a direct droplet infection of the baby from the mother. Yes or no? Yes. So, breastfeeding actually, increases the risk of COVID infection to the neonate when the mother has active infection, but as such it does not spread through the breast milk. Okay, so what does the guideline say? Does the guideline support breastfeeding, or the guideline wants the baby to be separated from the mother? Okay, I'll tell you. Okay, see, the guideline says keep the baby. The ICMR guideline says keep the baby in a separate room until the mother becomes COVID negative, until the mother turns COVID negative. Okay, or if at all they stay in the same room because of inadequate facilities, if they happen to stay in the same room, keep the baby at least 6 feet away from the mother. At least 6 feet away from the mother, preferably in 2 different rooms. If at all they happen to stay in the same room, at least 6 feet away from the infected mother. Okay, and regarding the breast milk, okay, the RCOG guideline encourages breastfeeding. Okay, encourages breastfeeding with mask. Okay, so with mask, the lady is allowed to feed. With mask, the lady is allowed to feed. You understand? With mask, she is allowed to feed. Okay. At other times, when she is not feeding, the baby can be kept away from the mother. During feeding, the baby can be brought close to the mother with mask. That's what the RCOG guideline recommends. Okay. And the guideline also says, for mother who is sick, okay, for women who are sick, that means for women who are hypoxic or intubated, when the woman is not able to feed by herself, expressed breast milk can be given. Expressed breast milk can be given. Okay. So, through expressed breast milk, does the infection spread to the neonate? What's your answer, guys? Does the infection spread to the neonate through expressed breast milk? No, it does not spread through expressed breast milk. Okay. In fact, there is an added advantage that the baby would get antibodies from the mother. Okay. The baby would get antibodies from the mother which are, secreted in the breast milk. Okay. So, this is about breastfeeding. So, let's have some MCQs here for our better understanding. Yes, we have some MCQs here. Which of the following statement is false about COVID-19 infection in pregnancy? Doctors, see the question. Vertical transmission is uncommon. What's your opinion on this? Vertical transmission is present but uncommon. True or false? The statement is true. Vaginal delivery increases the risk of vertical transmission. Is it true? Does vaginal delivery increase the risk of vertical transmission? Does mode of delivery affect the transmission rate? No. Vaginal delivery does not increase the risk of vertical transmission because the virus is not seen in vaginal secretions. So, this statement is false. Okay. Vertical transmission is not affected by method of feeding. Yes. Because it is not present in breast milk. Yes. Even the expressed breast milk does not transmit the virus from the mother to the baby. Okay. So, this is true. Vertical transmission is not found to cause congenital malformations. I told you this virus is not teratogenic. It does not cause congenital malformations. Okay. This virus is not teratogenic. Fine. So, among the 4 options, which is the odd man? B. Okay. See the next question here. Which of the following statement is true about COVID infection in pregnancy? Pregnant women contract the infection more frequently than the general population. Is the incidence of infection high in pregnancy? No, I told you the incidence of infection is the same. Only the severity is more. Okay. So, this is a false statement. Okay. Pregnant women are found to be more symptomatic than non-pregnant women of the same age group. This is again false. Okay. Even during pregnancy, most of the women are asymptomatic only. Okay. So, the percentage of women who are asymptomatic are the same for pregnant and non-pregnant population. Okay. Pregnant women are almost always symptomatic. Absolutely false because most of the pregnant women are asymptomatic. Severity is more for pregnant than non-pregnant women of the same age group. This is the true statement. Pakka true. Okay. Severity is more when the woman develops symptoms. Most common symptom of COVID-19 in pregnancy is? What's your answer? Most common symptom. What's your answer, doctor? Fever. Yes. Most common symptom is fever. Okay. See the next question here. COVID-19 infection in pregnancy is most severe in which trimester? Give your answers. Give your answers now. Correct. Infection is most severe in the 3rd trimester. Okay, next question here. Risk of which of the following is increased with COVID-19 infection in pregnancy? So we have 4 options here. What's your answer, doctor? Stillbirth, preterm birth, IUGR and congenital malformations. You know it is not teratogenic, it does not lead to malformations. It does not lead to IUGR. Stillbirth, it neither leads to IUGR nor it leads to stillbirth. So it increases the risk of what? Preterm birth. It increases the risk of preterm birth. This is the correct answer. And most of the preterm births are iatrogenic. Most of the preterm births are iatrogenic. Identify the false statement regarding anticoagulation in COVID-19 infection during pregnancy. So I told you all infected women should be put on low molecular weight heparin, right? Yes. Low molecular weight heparin, if indicated for other causes, should be continued. Yes or no? Yes or no? I told you, no, if the woman was already getting a low molecular weight heparin for other reasons like say APLA or heart disease or any other reason, this low molecular weight heparin should be continued during pregnancy. So this is a true statement. Okay, it should be continued during pregnancy. See the next statement. All pregnant women with confirmed or suspected COVID-19 infection should be offered prophylactic low molecular weight heparin unless birth is expected within the next 12 hours. This is again true statement. All women with COVID-19 infection in the postpartum period should be treated with low molecular weight heparin preferably until 6 weeks postpartum. At least for 10 days from recovery, preferably till 6 weeks postpartum. This is again a true statement. Thromboprophylaxis once commenced should be continued for 7 to 10 days from diagnosis. This is wrong. What did I tell you? 7 to 10 days from diagnosis or 7 to 14 days from recovery? What did I tell you? Yes, it's from recovery. Okay, thromboprophylaxis should be continued for 14 days from recovery. Okay, so this is a false statement. I know this question is little difficult, but INICET people, you can know this. It's better you know this. Thromboprophylaxis for COVID illness during pregnancy, because we expect out of INICET is, the toughest of the tough. Okay. See this one. Identify the false statement about COVID infection in pregnancy. Continuous electronic fetal monitoring is not required for asymptomatic COVID positive women in labor. It is only for symptomatic women. For asymptomatic women, it's not required. COVID-19 infection in pregnancy is not an indication for cesarean delivery. Yes, it is not an indication for cesarean delivery. We will not be doing cesarean for all women infected with COVID. Okay. Fetal blood sampling is better avoided in infected women. I told you, fetal blood sampling can be done because this virus is not shed in vaginal secretions. Okay. Where do you avoid fetal blood sampling? In HIV and herpes only you avoid fetal blood sampling. Here you can do fetal blood sampling. Okay. Entonox is safe for labor analgesia. This can be taken as true, but the preferred mode of analgesia is still epidural. Okay. So this is a wrong statement. Fetal blood sampling is avoided. Is a wrong statement. Deficiency of the following vitamin increases the severity of COVID illness during pregnancy. Which vitamin? Vitamin D. Okay. Vitamin D. Okay. So we have 2 more questions here. Identify the false statement about management of COVID-19 infection in pregnancy. Oxygen saturation is ideally maintained to more than 94%. What do you say? True statement. True statement. Okay, it's ideal to maintain it to more than 94%. Stop aspirin if the platelet count falls below 50,000 per cubic mm. True or false? This statement is again true. True. Next question. Antenatal steroids for fetal lung maturation can be given according to routine guidelines. Can we give antenatal steroids? Yes or no? Yes? Yes, we can. Steroids can be given. Steroids can be given. Antiviral therapy is better avoided for their teratogenic effects. What do you say? Antiviral therapy should be avoided. What does the guideline say? Should we avoid antiviral therapy? No. Antiviral therapy can be given. Okay. Antiviral therapy can be given during pregnancy. Okay. So last question here. What's your advice on breastfeeding in COVID infected women? Breastfeeding is better avoided in all COVID infected women until recovery. No. No. Even if the mother is not able to feed, we can express breast milk. Okay. We can feed the baby with expressed milk. Breastfeeding should be encouraged only in asymptomatic COVID positive women and not in symptomatic. Again, false. Encourage breastfeeding. That's what the guideline says. Encourage. With mask. Encourage. Express breast milk feed would not be ideal as virus is shed in breast milk. Again, false. Virus is not shed in breast milk. Okay, this virus is not shed in breast milk. Breastfeeding should be encouraged regardless of the COVID status. This is the perfect statement. Okay, breastfeeding should be encouraged. Even if the woman is badly symptomatic, express the milk and feed. Okay, but don't waste the breast milk. That's what the guidelines say. Okay, so this is about COVID infection in pregnancy. So these are some MCQs which we expect. Okay,